Hello, everyone. This is Charles from OPCA. It is 2 p.m. and people are still trickling in, so let's give it a couple more minutes before we get started.
Oh, okay.
Okay, some can and some can't.
Now I got it.
We're good. We have critical mass. Okay. Welcome, everyone. Good afternoon. This is where we're checking in on the proposed metrics framework, or should I say the metrics both OCHIN and non-OCHIN clinics on the implementation of getting those new metrics to making them report from this patient management redesign project. So I want to always distinguish those two things as we continue to check in. So really, the bulk of today's call is more of an update. We have an hour and a half scheduled, and we can take up as much of that time as needed in order for you to have clarity on where this project is at, what the milestones look like between now and October 30th, which is when your Q3 2018 reports are due to the state. But before we get into the content, I want to do a swift, quick roll call. Well, we do have a lot of people today. This is great. So want to see if Jamal, our colleague at OHA, is on the line. Good afternoon, Jason. Do we have anyone from OCHIN on the line?
Hi, Ned is here.
Good afternoon, Ed. I also see our colleagues from Arcadia. Oh, was that you, Ariel?
Oh, no, this is, my name is Jessie Robertson. I'm the Quality Metrics Program Coordinator here, so I work very heavily with Ariel and Ned as well. So another representative from that department.
Wonderful. Krista's nodding, so I'll take that as a good sign.
Excellent.
Our colleagues from
media here
oh, yeah.
on behalf of YVSWC.
Arcadia, right?
Yes.
Perfect.
And we also
So
have
any
Ben
other...
Cotton from.
Oh, welcome, guys.
Thanks. Also IBFWC.
Nice. Any other vendors on the line? Okay, let's see which clinics are on the line today. Anyone from OHSU Richmond, Mosaic, or Virginia Garcia?
This is Kavita Prakash from Virginia Garcia.
Hey, Kavita.
This is Marshall and Michael from Mosaic.
Marshall, hey. Oh, Jimmy, Mac, hey. Anyone else from OHSU Richmond on the line? Troy, I just wanted to hear your voice. Miss you, buddy. Okay. Phase 2, Multnomah, Yakima, Benton, and OHSU Scappoose.
Kevin Hedrick, Yakima.
Hello, Kevin.
Nicole Hoyt, OHSU Scappoose.
Nicole.
This is Melissa Park from Yakima.
Wonderful. Anyone from Benton or Multnomah? Okay, anyone from Rogue, Clackamas, or Reinhardt?
Okay, she's going.
Hi, this is Denise at Reinhardt.
Hey, Denise.
Hello.
How about Northwest Human Services, Winding Waters, or Neighborhood Health Center?
Erin at Neighborhood Health.
Hey, Erin. And who's in phase 5, Amy? Wallace or La Clinica?
Sandy from La Clinica.
This is Sarah Jade from Wallace.
Hey, Sandy, Sarah Jade. Okay. Did I miss anyone? Looks like we got most of you. And it looks like Chris Campbell from Benton just joined us too.
And we've got Ryan from La Clinica on as well.
Oh, hey, Ryan.
Hello.
Oh, and Troy and Erin at Richmond.
Hi, Erin. Hello, Troy.
Oh, I was going to say, you're not saying hi to Troy?
No, you didn't hear me earlier. I called you out, Troy.
Oh,
okay.
Comes with the territory.
Hey, we just wanted to hear your voice. Let's get back to business. So like I said earlier, really want to see where we're at in the process of both this patient management redesign that OCHIN has been leading on behalf of their members, and then from that, the quality metrics reporting, seeing where you guys are at for the Q3 2018 quality reporting timeline. I think that's going to flow just as it needs to into the discussion portion. I have a couple questions prompted to guide that portion, but it's really more of an opportunity for us to just get all the questions and issues on the table. And then, of course, reserve some time at the end of the call to reiterate action items and next steps. We've also recorded the call. Amy is taking notes, but also always nice to have a recording to resort back to. Recordings. So we'll either send out the transcript or some link to the recording. I'll Amy, I'm going to let you figure out what's best.
All right.
So it's really nice not calling this a proposal anymore. This is the plan. As a metrics work group, we decided to move forward with these 5 quality measures. They're all CCO measures. And to the right, you'll see we've highlighted the CCO averages for 2017. This came out of the annual CCO report that was published in June. Both Krista and Troy figured out the aggregate or the aggregate sum for each of these measures through that report. So you'll be hearing us calling those CCO averages, aggregate performance, or accountability targets. We use those terms interchangeably, know that we're talking about the same thing when we say those words. So, Krista, I'm looking towards you. Directly line up with how health centers are currently reporting them, and that CRC would require modification if it needs to be CCO aligned.
Yeah, so in terms of, sorry, I might not be understanding your question totally.
Oh yeah, what are the, what do clinics have to do to operationalize the numerator portion of these?
I mean, essentially, so like, OSHA is working on the report specifications with all the CCO specs. With colorectal cancer screening, the understanding has always been that, that cancer screening is potentially augment them a little bit if needed.
Okay.
Yeah.
Charles, can I clarify on the colorectal cancer screening as we're talking about that? When we talk about the
and Kevin, I know who you are, but say your name for the rest of the group. So.
Oh, Kevin Heydrich-Yakima. Colorectal cancer screening, when we look at the CCO requirements, have the continuous enrollment criteria. And I think what we agreed to was that we would look at our patient attribution using the PDR and then apply the metric criteria. Do they meet the colorectal cancer screening, but we're not going to apply the continuous enrollment. That's how it differs from what the CCO metric is.
Yes, you are completely right, Kevin, and I'm glad you brought that part up. I was trying to think about, like, the definition from, like, a population health standpoint, like he did versus that. But when it comes to the CCO specific piece around that of the continuous enrollment period, yes, we'd be looking at our APM patients, and the goal would be that we would be performing better than that 54.6 without a doubt, because, the CCOs are looking at unity enroll versus we're looking at those that we know we've seen, which is a little different.
Right, but we would use the CCO, the Oregon CCO metric quality definitions and reporting requirements with the exception of the continuous enrollment criteria piece.
Exactly, you are correct.
So anything else, Krista, anything else to say about these measures before I dive into the specs?
Not at this time.
Okay.
All of these, as far as I know, are set to be 2019 metrics as well.
Okay.
So I think we're good.
Nice. So what we want to get an update on is how we're aligning this metric population with your active APM population, and how the OHA PDR report could be used to do that. So we'll receive an update from OCHIN and non-OCHIN clinics on how that build is going. Again, those accountability targets, they're set. They're based on the annual OHA report. We just sent them out to the APCM Leadership Committee as part of a program update. So really depending on that committee to communicate that down to the people at the clinic that need to know that information. Let's see what else is on here. Yeah, any other questions about the specs before we get into the updates?
This is Erin at Neighborhood. I have a question about the PDR. We've noticed that we actually had some people fall off of the PDR, and we didn't think that was possible. So that's kind of concerning to us.
Yeah, let's, Jamal, is that a question for you to answer?
Yeah. So the only time that people should fall off of the patient data report is when they have an end date that is more than 12 months in the past. So that would be an APM end date more than 12 months in the past.
Okay, great.
So Erin, any concerns even with that piece of information?
No, since our reporting periods are rolling 12, that should be fine.
Okay.
Jamal, I also have another question because we get like the leakages reports and we're constantly, sending our new patients as we go. I'm not exactly sure how that affects the PDR, but okay. I'm not sure how that affects it. How does that affect it?
So the PDR is a reflection of members who are APM enrolled with the health center, regardless of if they're eligible or not. So generally, if somebody has a Prime ID or a Client ID, and they're not already APM enrolled with another clinic, they're able to be enrolled. And so what the PDR does is it reflects all of those members who have successfully been APM enrolled. Then as we determine that a patient leaked out to another primary care provider on that enrollment change report, we let health centers know which patients are scheduled to close because they have leaked out to another primary care provider. So when we then close those APM enrollments, generally on the next patient data report, you'll see that same patient in their APM enrollments, except they'll now see that their APM enrollment has an actual end date rather than that 12/31/2299 end date.
Okay, thank you. I was trying to figure out how some of these end dates work. That explained it really well. Thanks.
Okay, any other burning questions before we turn it over to Ochin? Okay. So I forgot to add. So, of course, want an update, see if we're on track with reporting the new metrics for Q3 of this year. Established the fact that we're using a 12-month rolling period. And just to ensure that this point gets carried forward, we're locking in these 5 metrics. We'll be reporting on them for a full year before really starting the conversation of amending and or onboarding new measures. So really want to lock into what we agreed to as a work group before making any changes. This last month, Kevin from Yakima proposed that we make some augmentations to the PDR report to include additional demographic fields. So sent out an email to the group trying to see if there were any concerns with that request. Hearing none, Jamal went ahead and approve that request. So Jamal, do you have an update on when clinics will see a PDR report with some expanded fields?
Yes, so by the end of this week, we do anticipate sending out the updated patient data report. That report has been created already, and with our previous data analyst moving on to other pastures, we're working with our fill-in analyst, Lindsay Newton, who's graciously covering. She typically works on the pharmacy program, but she'll be creating those patient data reports and sending them out by the end of Friday this week.
Mm-hmm. Okay, and then the final bullet point, this was something that was communicated to the APCM Leadership Committee yesterday. So Jamal's proposing that we start the quality metrics trigger period with Q1 2019. So trigger period, that's a period where your quality performance is being reviewed. So the whole kind of failing to meet 3 out of 5 measures over 4 consecutive periods is exactly what this period is. So that proposal has been sent out to the APCM Leadership Committee. This is just more of a point for you guys to know about as we're aiming to get these measures in place by Q3. And we'll quite frankly say we'll have another quarter to iron out any additional details and kinks in this new metric set, and that we truly want them to have them ready by this Q1 2019 time period.
So, Charles, clarification from Kevin, again, Yakima. So the Q3 report, which is due October 31st, and then the Q4 report for 2018 will not be part of the trigger period. That will start with the January, February, March Q1 2019 report?
That's what Jamal is proposing. And that's for the leadership committee to respond to. But yes, that's what's on the table, Kevin. Any follow-up to Kevin's comment? Okay. Thanks for clarifying. So Ned, I have the slides from last month's webinar. I've really just given you the floor to update as you see fit.
Okay, can you hear me well?
Yes.
Great. So we're on track. We should have, our aim is to have the reports available in early October for testing and QA by the members, by the APM members, and then we should have them ready in time to, based on that, schedule for the October, end of October deadline. Right now, so lost our reporting analyst who was our lead APM sort of guru, but that's being resourced, and again, I don't see that at this time as a barrier. So our plan is to get these out to members for testing in the beginning of October again, and given that the quality metrics are aligned with CCO metrics, which are aligned with CMS metrics by and large, again, this the larger task is to align this, as with everything else, to the denominator of just APM patients. But that's part and parcel of why we're doing the redesign to use a registry so that we can limit all of our reporting efficiently to just the APM patients using the registry. And again, that should also have some benefits as far as making management of the patient rosters easier. Having said that, there's still some details to be worked out about how the registry will function and be updated from the PDR. Kavita and Sarah Jade were nice enough to meet with me yesterday to discuss some of the fields in the PDR and how they should be filtered to get an effective approximation of the current APM list of patients. And that generated a few sort of questions or suggestions that I'll share. I can do it offline with Jamal, but just to give you the heads up, Jamal, that's coming, mainly around the coverage types, and I think it's the health, column W, the health program benefits package. I think there's a concern that there are certain programs that would be carved out, like Cover All Kids, that aren't necessarily included in the PDR right now, and there was a question of whether they could be. So I'll provide you a little bit more detail about that, Jamal, when I make the request, but I just wanted to give you that heads up. And then just for, I guess, to keep everyone in the loop, the means that Kavita and Sarah Jade sort of outlined as the easiest and sort of the best way right now to filter the PDR to get to close to the current list. And again, there's still some QA and testing going on to see what remaining differences there are after this kind of filtering is done. But to filter the APM end date and the eligibility end date, so that's column E in the current version of the PDR, column E and column T, just filter those to the 12/31/2299 patients, and then to remove from column W, to remove all of the rows that have the column, which is CWM or CWX, and then the med benefit package listed. So filtering out those gets it fairly close to the final list, or close to what the 820 payment file shows. And again, we're doing some more additional troubleshooting on that to see if we can get it even closer. But I guess I would ask the group if there are other benefit packages that you're aware of that can show up in the PDR that should be excluded because they're part of a carve out. Let us know. So those are the ones that I know about now. But if there are others that you're aware of, please feel free to reach out and let me know those.
Hey, so Ned, I'm trying to translate your question. The technology is a little fuzzy. So I want to learn from the group if there are other benefit packages that should be either included or excluded from the filter, the APM filter for reporting.
Yeah, so if you look at your column W of the current PDR, it's the health program benefit package, and things like Callum and med are carved out or filtered out, or should be filtered out because they're carve outs. If there are other benefit packages, so the question for the group is if you're aware of other benefit packages that we should add to this sort of list of things to filter out, to share with everybody, that would be good for everyone to know about. And then the question specifically for Jamal is there any way to get the Cover All Kids benefit recipients noted in that column as well, so that they can be excluded? Because right now, the only way to exclude them, Sarah Jade had a process for doing that that's fairly reliable, and Sarah Jade, feel free to speak to that if you want. But
yeah, this is Jamal. This is Jamal. So we can't carve out the Cover All Kids population based off of the benefit package / health program, but we can filter them out based on the PERC code, the PERC code. So I can follow up with a list of the Cover All Kids PERC codes. I think most of them are pretty self-explanatory and readily listed in the PERC code description. But let me follow up with the distinct list of all of those PERC codes. And the reason that it can't be done off of the benefit package is because there are some, so the CWX, the Calum Plus benefit package, where there's a pregnant non-citizen. Those members oftentimes do generate per member per month payments, but specifically if they're CWX and part of the Cover All Kids, so a pregnant non-citizen who's a child, that actually wouldn't qualify for the per member per month payment. So again, the Cover All Kids program is really listed at the PERC code level. So there's likely even some OHP Plus members with the BMH benefit package that are Cover All Kids, and the way to filter them at the Cover All Kids population out is using the PERC code. And the PERC code
so
is...
you'll be able to... Oh, yeah, okay. Go ahead.
Yeah, I'll definitely follow up with a list of all of those PERC codes, but the PERC code is a data set that's always been within the patient data report, so there's no need to add an additional data field. It's readily available.
Okay, yeah, it looks like it's column U right after the eligibility end date.
Right, and that's going to shift around a little bit because we've had to make some updates to the patient data report, as you all know. So the columns will be a little bit different based on the changes the demographic changes that were made.
So Ned, it sounds like you have to hold off on kind of memorializing those columns into the build.
Yeah, and rather than actually in the build, this is going to be process. This is going to be something that centers will need to filter these with the clinic before uploading that filtered list into the registry.
Okay.
So, but I will certainly memorialize it into a documentation that walks through, and I'll wait until the revised PDR comes out to see what columns those are before we get too much into the details. But if there, I just want to reiterate, if there are other things that should be filtered out, to please feel free to let us know and share that with everybody in that documentation.
Nice. So Arcadia, OHSU, and I don't know if Northwest is on. Are you guys, how are you working with the PDR right now? What updates and barriers do you have that either OCHIN can help troubleshoot, or that would be helpful for Jamal to know and help troubleshoot? Let's start with Yakima and Arcadia.
Sure, happy to start. So we'll be using the report in order to generate our measurement population with each measurement period. And our only blocker was the need for some additional demographic information, which at this time we're expecting to receive, and we don't expect to have any other blockers or questions.
Okay. OHSU, who's speaking for you guys?
This is Erin. I can just say at a really high level, we are in week 2 of our EPIC transition, and SCAPUS is a few more weeks in, but not anticipating any huge barriers. Same thing along the lines of additional patient demographic information. The PDR will probably help, but we'll be reviewing actually our registry plan next week. We'll keep you posted.
Nice. And are there other non-OCHN clinics on the line? Okay. I wanted to go back to a question. Ned, as you worked with Sarah Jada and Kavitha, like how aligned were you able to get the PDR with the 820, and like what's a good enough point if that question makes sense?
I think it does, and I'll defer on in a moment to Kavitha and Sarah Jade. I think it'd be good to hear from them what their sort of confidence was in that. But from our standpoint, ultimately it's a question for Jamal. Jamal had mentioned, yes, I think we can get 95% of the way there, if I recall correctly. That was his sort of guess about using the PDR to reflect the 820 or the current APM patients. And certainly we, I think, have gotten that close and a little bit closer, but it's under 5% and probably more than 1% right now without having done more digging yet this week.
Let's start with Kavitha and Sarah Jade. Any comments or additional concerns around that?
This is Kavitha. So when we had that discussion yesterday with Ned, we decided on those filters, like filtering for the filtering on the eligibility date, as well as filtering out certain benefit packages, right? And when I compared the results to the total list of patients that I had on my 820, it was off by about 700 patients, which is about how much? Like about 2% or so. So it's not a great. It's not a huge difference, right? It came pretty close.
Yeah, that's impressive.
Yeah, that was the same experience that I had. I think the biggest issue, as Ned mentioned, was the cover all kids. But besides that, it looked really good.
Okay. Nice. So it looks like we're making headway there. Jamal, any comments?
No, it's great to hear that Ned and OCHN in the clinics have gotten that close. One way to look at it is the 820 report is always going to be those patients who are being paid for, and the system is always only going to pay for a time period where the member is APM eligible. Whereas the patient data report, as it stands, is always going to be all patients who are APM enrolled or were APM enrolled at least within the last 12 months. And so it can be much more than just who's eligible when that patient data report is sent. So there should always be a means to get down to just those APM enrolled and OHP eligible members. And so, I think once we send a list of those cover all kids per codes, it should probably get the clinics even closer, which is very encouraging.
Right.
Hey Jamal, I had a question. This is Jimmy from OHSU. So when we're doing the quality metrics, should we be reporting on people we're getting paid for or people that are on the PDR?
I believe the methodology that we're looking at is using the PDR as a proxy to who's being paid for by essentially filtering down to those APM enrolled and OHP eligible members. So does that answer your question, Jimmy?
So should we be using, so the PDR, the registry we're building right now is based off the PDR, but not everyone on the PDR we're not necessarily getting paid for. So I'm just trying to understand what we're going to be reporting on.
Yeah, I'm like what's programmatically. I know like we look at the PDR more as a technical solution. But programmatically, Jamal, it sounds like you're saying the PDR is more reflective of the APM population that you were paid for at one time during that 12-month period, and that was under your care. Otherwise, they would not be on the PDR.
Yeah, I think we're saying the same thing, but another way to say it
Almost
is
there.
The PDR is going to have all APM enrollments, unless the member had their APM enrollment closed down and the end date on that closed down APM enrollment is more than 12 months in the past. So if OHSU Richmond added a member to their APM effective March 1st, 2013, and they've never closed down, they're going to continue to show up on every patient data report. But if they had a member who had closed down July 1st, 2017, and we sent the August patient data report, that member is going to not show up on that next patient data report. So, and again, you know, a member, people can be APM enrolled as long as they have a Prime ID, otherwise known as a client ID or a recipient ID. So if I'm an OHP member and I'm getting my care at Virginia Garcia and I was APM enrolled with Virginia Garcia starting 1/1/2018, but I lost coverage in April of 2018 and never got it back, I'm going to remain on that patient list indefinitely, because just because I lost OHP eligibility doesn't mean I lost that recipient ID or Prime ID. And so even those members who are no longer eligible can still be APM enrolled, and that's kind of the need to filter down. And the intent or the purpose of allowing for members to be APM enrolled regardless of their eligibility is understanding that members can oftentimes churn on and off of the APM, and we didn't want the focus of health centers to be managing that churn and having to start patients and close them down. Clinics can just kind of rest assured that they can enroll that member and continue to care for them regardless of their eligibility, and whenever that member is OHP eligible, per member per month payments are going to generate.
And going from the 820 to the PDR helps alleviate some of that churn that OCHIN was concerned about when building this registry. Ned, is that correct?
Yeah, and I think using the PDR also gives us because the PDR has that extra information, it's an easier thing to use one file to manage the list, and there'll be an easier way to tell who's on the list, who isn't, and why.
Mm-hmm.
This is Kavita. I have a question. So when you're comparing the APM 820 to the PDR, and you filter the PDR the way we've been talking, I would expect that the filtered PDR would have more patients than the APM 820. Is that correct?
Well, theoretically, yes, actually, that would be correct.
Yeah, because
it
that's what I was
somewhat
expecting.
depends on. Yeah, so one of the things to kind of identify about the 820 is there are multiple capitation cycles that generate an 820. So you have the monthly 820 report. So for members that are APM enrolled ongoing, say the member was first APM enrolled January 1st, 2018, and we hit the monthly capitation cycle at the beginning of August, and the system knows to kick out that per member per month payment for August. And then the patient continues to be enrolled, but they are there's no changes to their enrollment. So there's successive weekly capitation cycles that pick up any changes and pay. So if you had added another list in the middle of the month, that weekly capitation cycle would pick that up and pay it. But with this particular member, let's say they're continuously enrolled since January 1st, 2018, those weekly cycles aren't going to show any additional payments for them because there's no changes. And then once you get to the September monthly PMPM, or the monthly capitation cycle again, it's going to kick out that September per member per month payment. So if we're talking solely about the monthly 820 report, that monthly report is going to pay out all of the per member per month payments that hadn't been issued. So for all those patients that are continuously active and enrolled in September, it'll kick out the September per member per month payment, plus any additional payments for new enrollments that were added. So say the September capitation cycle is coming up and it's getting ready to pay the September PMPM, but there's also a list of 10 patients that was just uploaded right before the cycle, and their enrollments date back to April 1st, 2018. So that monthly cycle is going to pay the normal September payments, but then for that list that has the changes, it's also going to catch up on that and pay April, May, June, July, August, and September. So the patient data report, again, is going to be kind of that entire universe where, you know, these are all of the members who are APM enrolled, whereas the 820 is going to look at a period in time and say what needs to be paid for this specific period based on the changes in the past week for those patients who are actively enrolled. So yeah, I think you can realistically say that the patient data report is always going to be somewhat larger than the 820 report, especially unfiltered. But even when you get down to filtering to OHP eligible and you're comparing that to the monthly patient data report, it should be, or the monthly 820 report, it should be fairly close to that monthly 820 report. I don't want to say exact because there are little nuances like cover all kids and the like. But then comparing the patient data report to the weekly capitation file or the weekly 820 report, it's going to be much larger, right? Because those monthly per member per month payments aren't being issued during those weekly 820 cycles. Does that make sense?
That makes sense, but see, that's why I'm a little confused, because when I filter the PDR the way we discussed, like I said, there's about a 2% difference, but what I'm saying is, like, I'm seeing less patients. So I'm seeing 700 less patients on the PDR when in comparison to the APM 820 report, which I was expecting to see more for the reasons that you were explaining.
Yeah, that is odd. I think we'd certainly want to look into that and identify any patients that are generating payments but not showing up on the patient data report. So if you have a list that you could send offline, I would appreciate that, and we can research.
Okay. Jamal, it's Erin at Richmond, and I'm wondering if we can get like some documentation on like all these definitions and like criteria that's being talked about? Or is that in the parking lot or on the work plan somewhere? I guess this is a bigger question, not just for you. But I feel like something would be beneficial to have sort of like a...
Yeah, I think we've historically provided an APM patient data report guide. So given all of the changes, I think now's a good time to update that guide and make sure that gets sent out to everybody.
Well, this is probably
this is Ned.
This would be more of a, like, the bigger question than, like, that sounds great, updating that, but then also updating some of the specifications around each specific metric.
I have an update around that, Aaron. This is Charles at OPCA. Jamal, I hope you don't mind me chiming in. So,
not at all.
You know, us at OPCA, we are pretty aware of all these changes, and knowing that we have to reflect them in like the APCM reporting guide, which Amy and Jimmy Mack developed a couple of years ago. So needing to recognize that parts of that are outdated, sorry. And the reporting instruction sheet, which Brandon OPCA sends out to health centers and the template. So we know that the ball's in our court to update those guides. We just had a meeting around it yesterday, and our priority is to really update the instruction sheets. And then I know Amy and Krista are going to talk about a timeline for updating kind of the broader reporting guide, Aaron, that you're referring to. Also want to loop in, Ned, I know that there are, of course, additional workflows that health centers have to train around, more so on this patient management redesign process. So want to see what communication plan you guys have in mind and how we can partner together on rolling that information out.
Yeah, so we'll certainly, and we're designing in one area. Jesse has really taken the lead on designing workflows for the current process, and then as we update this to reflect the future state or the future version of the process. And as we do that, as we document the filtering that we're talking about, we'll share that not just with Ocean members, but we'll certainly share that with the wider group, so that ideally everybody's on the same page as much as possible, and especially with respect to the filtering aspect of the PDR, and making sure that it's very clear what we're recommending that's based on these discussions and Jamal's input. We'll make sure that documentation gets out to certainly the Ocean members, but also to OPCA to be shared with others as well. And same thing for the workflows. As much as insofar as they don't show any Epic screenshot or other things we're not allowed to share outside of our membership, we will make everything available to others as well.
Ned, Ocean, thanks for being such a steward of the program. Really appreciate that. Any other questions before I prompt some more pointed discussion questions? I'll just get to that page. Okay. Question number one. What are some milestones that we need to keep a pulse on between now and October? both on the patient management redesign process and the quality reporting. Yeah, the quality reporting.
And I would say pro PCA and OCHIN and non-OCHIN too, because we want to make sure that, you know, like Charles said, we identified the instructions workbook as one of the things and the templates, but is there something that, you know, we need to make sure we do?
Yeah, is there a demo that will be rolled out and that we want to help host and stage?
Updating the dashboards, essentially, et cetera, so. And OCHIN, I know there was, reluctancy to commit to a timeline at our last call. So this, thinking now it's time to really get those milestones in place if we're targeting that Q3 2018 reporting deadline.
Yeah, I mean, so again, I can reiterate that our objective right now is to have the reports, the updated reports that reflect the registry as the denominator, so the current APM patients as the denominator, based on the definitions that we've been talking about, at the beginning of October for testing in QA among members, and that's then that gives us a month to do that testing. A few weeks to do some testing and get us feedback, and then another 2 weeks to make any changes that are needed based on that. That's right now. That is much information as I have. I think the demo is a good idea about the registry just to show the functionality. It'll be fairly straightforward, but just because it's different than the current setup, we certainly can do that. I don't have a timeline for when we'll be able to do that, but I think that makes a lot of sense. And I think that'll happen in advance of of sending out the reports for testing. So I guess I would say in September, if you want to put a little more specificity around it, I would say that we should shoot for the demo by the last week of September, if you're looking for a date.
So Ned, I'm trying to line up the dates you put out there. So October 1st, that's when you would like to open the process up to some QA with the health centers. And then, sorry, can you write that up? I don't know if.
Sure, I can send that to you in an email.
Do you mean the chat box?
Yeah, the chat box.
Yeah, I almost wonder if maybe we can write down what we're hearing on a single document to make sure we're all on the same page. And granted, we'll be sending out notes and everything.
Yeah. It'd be nice to walk away with those details.
Yeah.
Will the reports be business objects reports, Ned?
Yeah, the ones that are in business objects now, again, will be updated in business objects just to reflect the APM patients, the new denominator, and then we'll, of course, be adding the quality metrics reports that will have the same denominator. And those will function the same way that the CCO metrics reports in business objects do, and essentially because they're based on exactly those reports, but limited to the APM denominator.
Okay, that sounds great. Thank you.
Sure.
This is Jamal. I just wanted to let OCHIN know that there is one additional data element that may prevent per member per month payments and patients showing up on the 820 report, and that's the living arrangement. So I am seeing that out of the 171,000 members attributed to APM health centers, there are 2 members that have the SH living arrangement code, which stands for their living arrangement is the Oregon State Hospital. So I believe that code prevents the system from generating per member per month payments. Yeah, so once again, if the living arrangement is SH Sally Henry, that's the last data element I believe that you'd want to filter out.
Great, thank you so much.
I mean, you do want, yeah, you do want to filter it out. I don't mean that it's the last one. Yeah, semantics get a little bit weird there, but filter that one out as well.
I read you. Roger.
Ned, I remembered I do have a project checklist slide. Can you back your update into these? Oh, you just typed it in. So last week in September, plan for demo of registry functionality for OCHA members. October 1st, business objects report available for testing only. Type away. And last week of October, business object APN reports go live.
Okay. So it sounds like a month for testing.
Health centers.
Yeah, that's the ideal. So really 2 weeks for what I would say is 2 weeks for testing, and then a week or so to implement any necessary fixes, because we want to give ourselves a little bit of runway to address any issues that are brought up during the testing.
Health centers, any feedback?
That seems doable. Questions, comments, concerns? Speak now, forever hold your peace.
Will this give you enough time to produce and turn in your Q3 2018 reports?
So this is Sandy at La Clinica. I think I have concerns. I think that 2 weeks for Q&A and testing and changes and having the reporting done by all within October. Maybe once I see the demo, I'll feel a little bit more comfortable with the process. But I think that timeline it seems pretty short for the turnaround on the feedback loop and any adjustments.
Andy, thanks for catching me. That was a trust fall. Yeah.
Thank you for saying that. I think we're worried too.
Any other feedback? Are there health centers that think this is doable?
This is Sarah Jade. I'm definitely happy to test out the reports, but one of the other factors is that the charts would need to be closed for all the elements for us to test out the reports. And sometimes that is a little bit of wrangling here at our clinic before we could even start doing testing. So that's just something else to think about.
Ned, I have a question. Once the reports, Chris, that's a comment. Chris from Benton, he agrees the tight timeline doesn't leave much room for competing priorities for his team. To my question, and of course, this would need to be vetted out further and have Jamal's approval. Can you kind of retrospectively report on a period once the build is done? I don't know how dynamic this business object report would be, but is it knowing that we are building a new, a new way for identifying and reporting on patients, could there be some retrospective reporting done for this time period? I'm just floating that out as a possibility.
For which time period?
For Q3 2018.
So you can report retrospectively, but keep in mind that the query will be designed to look again from the most recent PDR of the quarter, or that the most. So the query will be based on the registry, and what we've been discussing, I should say, is that means that that'll reflect the patients in the most recent PDR. So if you were to run this query for prior dates and look at who's on the registry, it's going to tell you who's on the registry now as opposed to in the past. So I think you wouldn't want to do it too far into the past, is my assessment.
And Ed, based on your vantage point, when would health centers be able to report on their population for Q3 2018, which would be the July to September time period?
Yeah, so I mean, I've given you my timeline, and I appreciate that doesn't leave as much time as we'd probably like for testing, or it sounds like there's some discomfort with that, and I understand, but I mean, that's as far as developing the reports, given that we're going to be bringing someone up to speed, that's what we're going to do. We'll try and be better than that, but what I don't want to do is overpromise and underdeliver. I'd rather do it the other way around. So we'll certainly aim to have it before then, but that's what I can commit to is the beginning of October. And if hopefully that will give us most of that month, barring any issues. And again, I say that what I'd like is to find out in the first couple of weeks of that month, so we have time to do any fixes. But we're not reinventing the reports either. Keep in mind that we're just restricting the denominator to the current APM patients. So the reports will function in the main just like they have. It'll just be limited to the APM patients. And the other thing I would say is that if the accountability mechanism isn't kicking in until the first quarter of 2019, I would also suggest that we may be able to use this quarter as as a means of figuring out what works and what doesn't.
This is Kavita. If when you say testing the reports, right? If you're just referring to using the new reports that are based off the PDR and the registry to calculate the results, right, of these clinical quality metrics, that may be doable. But if you're talking about testing as far as I guess once we transition over to this registry, we're no longer going to be using the APM modifier, right? And testing that and seeing if we're, the 3131 generated from these from the new method is accurate. That may be a little bit more trickier.
I think it'd be closer to the first thing you mentioned. So what I'm talking about is specifically the reports that are due on the 31st. So as we, my expectation is the registry itself will be done. It's mostly the registry functionality is being worked on now and it's mostly done. So those kinds of pieces we can test before then. So we'll have more time, and the more complex things, we'll be doing QA internally on before we even turn it over to you. But I really, I think that's a good point. And again, we'll have more time to test the more complex things that revolve around the registry itself and the generation of 3131, for instance.
Yeah, I think it's doable to meet the quality metrics deadline. I think. I'm just speaking just from what I'm hearing. That may be doable. A couple of weeks may be doable. Only thing is, if we're running into issues, then we may have problems, right? Like if after testing, we find major issues, then it may not be enough time to correct those problems, right? And submit.
Yeah, understood.
And make the deadlines.
Understood. Yeah.
Yeah. So this is Krista. I'm just going to throw out a proposal and see what you guys kind of think. So thanks again, Ned, for kind of giving a high-level overview about just what the timeline looks to be shaking out. It seems like there's a couple clinics that think could be doable, and then there's also a good chunk that are kind of concerned about the 2-week testing time. I think that's pretty fair, just thinking about, kind of putting on my old clinic hat, just generally how long it took to test and get on the same page and everything along those lines. 2 weeks can be a little ambitious. That said, Jamal had added that he's pretty flexible in terms of, he would be fine with a 30-day delay on this initial quality metric report to November 30th, but with that expectation that things past essentially Q1 on would really be reflective of this model. I want to call out that Jamal added that as a potential option, and I want to acknowledge and thank Jamal for that flexibility. My proposal to the group, just knowing that part, is that we stick with that original October 31st, and really, just because, again, we've been reporting data on a quarterly basis. Everything's really set up on that quarterly basis. There's also other initiatives we send out the templates for that are coordinated with this. I think we move forward as planned, and really Q4 is seen as kind of what you suggested, Ned, a test quarter where we expect that we're going to find things past that 2-week window.
Q3.
Or Q3, sorry. Got my quarters all mixed up. The stuff that's due August 31st. October 31st, goodness sakes. Okay. That's due October 31st. We can anticipate that it's not going to be 100% perfect. And that will, we'll all be on the same page about that. And it's not an issue, again, because that PIP clock is not going to start until Q1 2019, as you guys saw. So, I think the only thing to consider there, if the group is okay with that, is that, maybe there's the demo, there's 2-week testing, revisiting, and then seeing, what did we find during that testing, and then doing, a second testing round, or elongating that testing window in general, past when clinics have already submitted their data and continuing to refine it and retune.
Yeah, and Q4 is another quote-unquote testing period since the PIP clock hasn't started.
Right, you're correct.
Yeah.
Sorry about that. Yes. So essentially, it's a good chunk of time to make sure we get this right. But I am hesitant to change any timelines just because we've been doing this quarterly for a long time.
Running like clock.
Also, we've been talking about getting this up and going with October 31st really being that date. And I propose that we kind of stick with that and keep in mind that the data might not be totally what we want. My understanding with Charles is that this won't impact payment at all, like the payment files or anything along those lines.
So I'm just going to see what are the thoughts about that being as the proposal? Questions, comments, concerns?
Hi, this is Sandy again from La Clinica. I feel that having Q3 more of the testing, and I mean, I'm good with keeping on track for the October 31st being the hard date, but I do feel more comfortable with having a quarter of testing, just because we'll be new to this, new workflows, and the whole registry feature itself will be something that La Clinica will be using for the first time.
Okay.
Let's flip it. Any concerns? Great. Hearing none, it sounds like we have a plan.
Any questions or concerns from you, Jamal? Does that sound like a good plan from your vantage point?
Yeah, that works for me.
Great. All right. So we will OPC internally find some way to definitely flag, you know, because we look at all this data retroactively too. Find some way to flag internally about just the nuances of this quarter 3 data, and then, you know, possibly quarter 4, obviously, okay, which hopefully will be more refined up to that point.
But Ned, Ochen, keep your eyes on the prize. No wiggle room there.
No, I wouldn't expect that, and I think no matter what happens, it'll be best for us to shoot for to having this done in October 30th, and then or 31st, and then to be able to take it as an improvement cycle after that. That would be my preference.
Yeah.
Too. So I think that's a good plan.
Sounds great. And October 31st, Halloween.
Wow.
Okay.
Well,
sounds great.
That's the call, everyone. So we'll be following up, Amy, with like the discrete action items, as well as the notes for recording. Any other requests or questions before we call this call good?
Just want to thank Kavita and Sarah Jade again for their help really walking through the PDR and the 820 this week. That was really helpful. I think we came a long way with that, or at least I did, so that was helpful for my understanding quite a bit. Incidentally, the PDR isn't something that we regularly see at Ocean or receive on behalf of the site, so it was really helpful. So thank you.
Yeah, let's applaud our clinical champions, Sarah Jade and Kavita. Thank you for taking the charge.
Yeah. Yeah, no problem.
Okay, I feel like we got some wins on this call. Thanks again for this hour and a half, guys. I know your days are busy. Move forward with the September call just to...
Should be the demo?
Yeah, we can link that with the demo. So yeah, we'll see you guys on the September call.
Thank you.
Thank you.
Bye-bye.
Thank you.